All right, turn to vitamins, minerals, and trace elements. Now we're going to apply it. So vitamins, minerals, and trace elements. Now we've learned the concept, which means the signs are the same. What the? Break it down. The signs of any of these deficiencies will be what? Tachypnea, dyspnea, poverty, the symptom. Weakness, shortness of breath. Angie, the infections. Pulmonary UTIs, Nick. What's the skin look like? Dry in the hair. Dry and brittle nails. Brittle bone marrow. Suppressed. What about the breast size? Breast size. Atrophy, sperm count. Low. What cancer are they predisposed to now? Skin followed by GI followed by bone marrow. What infections will they get? UTIs and pulmonary infections. What's the GI symptoms going to be? Nausea, vomiting, diarrhea. What part of the nephron was shut down first, Amika? PCT, and the most common cause of death for all these deficiencies, Amika, is what? That woman's been empowered. That man's been empowered. I didn't hear nothing new. We just covered every vitamin, mineral, trace element without talking about it. That means all that's left, folks, if they all have the same signs, symptoms, infections, complications, and cause of death, that means you ain't told me squat. You ain't told me squat till I hear one more thing. Lord, what do I need to hear after that? I got to hear the clue. Now I got to tell you the clue for these diseases if you want to get a point when you get to the exam. Everybody understand? Let me show you further application. Now this is, I get a lot of kick out of this because you're like, if a medical school invites me, then they say, oh, we want to know, what are you doing down in Champaign? How come you get all these high scores? I said, invite me down here. That way I get a free trip, see? That's how I get them. I said, yeah, invite me to your school. I can show you. So I come over and show you. I always pick something in the field of whoever their dean is. Because he's supposed to be expert, right? So I just take something out of his field and then, boom, show him a concept to wrap up everything you know in one concept. A minute ago, you thought you knew something. All right? So let's say that Lou used to learn his safety. One I went to was in St. Louis. The dean there, one of the deans that was there, I had about 8 people, and I wanted to demonstrate what it is I do in Champaign. One of the deans was a surgeon. So I said, watch what I'm going to do. I said, I'm going to program the crowd, and I said, after about 10 minutes, I'm going to start asking them questions, and I bet you they'll be able to answer them correctly. And they're all like, what? What do you mean? How's that going to be right? Well, you see what just happened. All of a sudden, they saw the concept with me. I fired away questions quickly. They understood it. And then I looked at the surgeon. I said, now, Mr. Surgeon, do you understand why you get a UA and a chest x-ray before everybody goes to surgery? And his jaw dropped. He had no idea. That's why you always do that. See, that's what I'm telling you, folks. Everybody's reading articles. The article says, hey, get a chest x-ray, UA, and everybody go to surgery. Why? Pulmonary infections? UTI. But nobody tells you this. You just keep following what the article said. And then when I show him that, oh my God, then he realized, holy cow. Never thought about that. I said, that's where it comes from. I said, but they didn't tell you that. They just trained you. You've been doing surgery for years. But I'm telling you, I can ramp up everything that you're doing as a surgeon. Just a couple of concepts. Tell you how to manage any patient in surgery. That's how Rick knew how to manage. In every field, he knew more than the doggone expert. Dr. Shaw, same thing. How do you know more hematology than hematologists? Wait till I break it down for you in biochem. That's where it all came from. I said, holy cow. And then when you get to class, they talk about Heinz bodies and this, that, that. All right, great. Could you please tell me where anemia really came from? That way I can figure out anemia for myself? Man, all right. Vitamins, minerals, trace elements. The beginning goes a little something like this. Hey, you know, every now and then, I get on the road. Okay? And I like a transition. So that means I look at somebody, Mayuri, and then next to Mayuri is Antonia, not Antonio, Antonia. All right, so anytime I look at you and I say, tell me what I got to do. Lord, tell them what I got to say. You got to say, break it down, Dr. Francis. All right? So when I go on roll, I like a little transition before I go. Okay, man, here we go. The beginning, baby. Vitamin A, vitamins, minerals, trace elements. Vitamin A, first got to tell you normal. Remember I told you, focus on normal before we start talking about abnormal. The normal is vitamin A is used for parathyroid hormone receptor, function. Vitamin A, cofactor PTH function, necessary for CSF production, and necessary for epithelial cell maturation. That means anytime you want cells to mature faster, give them a little vitamin A. They will do that for you. Right? Most unique function, however, for vitamin A is night vision. And then it's also a mild antioxidant. So these are the normal functions. Therefore, Antonia, if I'm missing vitamin A, do you see where all the problems come from? Does everybody understand what I'm saying? You understand, Jim? Look at that. See what leads it off? Its most unique function. If you want to get a point on a test, that's how you get the point. They want to see, did you understand the most unique function is what's going to bring that patient in to see you? Okay? Poor night vision. But on the boards, they'll switch it up a little bit, Mayuri. He can't see when the sun goes down. Click, next question. He can't see when he goes inside out. Click, click, next question. He can't see when he goes in the shade. Click, and move. They don't always have to use these same words. Remember I told you, the test writer can change the words. But as long as you know the idea, folks, that idea will never change. That's why I want you to focus on the idea. Okay? It has to do with low light. Anytime there's low light, all of a sudden the person can't see, vitamin A. Okay? Decreased CSF production is going to be asymptomatic. You won't even know. Okay? Anytime you have less CSF, your body does not know. Hypoparathyroidism, however, you will know, Monica. If your PTH is low, your serum calcium will be low and your phosphorus will be high. Whenever PTH is involved, Angie, your calcium and your phosphorus are always in opposite directions. At least try to get that. Anytime the calcium and phosphorus in opposite directions, Sharice, it has to be a PTH problem. You understand me? You understand, Z? Okay, that's the differentiator for vitamin D we're going to talk about later when they're in the same direction. And then finally, 2 steps to getting it right. Almost every time, folks, calcium and the hormone always go in the same direction. Never you forget, calcium and the hormone got to be in the same direction. So this is hypoparathyroidism, so I start with low calcium. And that means phosphorus got to be up. Okay? All right. And then epithelial cells will fail to mature. Well, look at AML or promyeloblastoma leukemia. That's why I added this as a new clue. Translocation 1517. I do it in leukemias. You'll hear it again there, but I wanted to kind of touch on it here. All right. Translocation 1517. Promyeloblastoma leukemia. They give them vitamin A so that the cells will mature a little bit into AML. What that does for you, Shweta, allows you to live a little longer. Because promyeloblastoma can be dead in a few months. AML, maybe got a year or two. That's a lot better. Well, they're going to do more than that, Joseph. That means if you have any disease where you wear away the lining of any organ, and I ask you, how can you regenerate it faster? You give them what vitamin, Joseph? Vitamin A. So that means if they give you a child with measles, Ramathea, who's worn away his pulmonary epithelium, and I ask you, how can you regenerate his lung epithelium faster? You say what? Does everybody understand that? Okay, that's the key. It doesn't matter if they change the context, don't you go changing your answer. Okay, it could be a cancer, it could be measles, it could be anything. I don't care. But if you tell me that that disease wears away a lot of cells, and of course when we talk about infections, we'll talk about the infections that wear away a lot of cells. I bet you I know how to get those cells to come back a lot faster. And therefore change the prognosis. That's the point. That's what management is if you understand what's wrong, then you understand how to correct it. Or at least what to correct. Rather than just memorizing an article that says do this, do this, do this, but you don't know which order you should pick it when you get to the test. Okay, so vitamin A deficiency. Vitamin A excess. What if you have too much vitamin A, Gretchen? And now you're going to have too much CSF. You'll have problems now. Because anytime you have too much CSF, Bindia, is that right? Bindia, Antonia. Okay, Bindia, Antonia. All right, got it. All right, let's see. Eric. There, I got it right? Eric, Joni? All right, cool. So if you got too much CSF, you're going to increase the pressure in your brain. Does that make sense to you? So a headache will be your symptom. Look in your eyes, evidence of intracranial pressure is called papilledema. You understand? You understand, Joni? So pseudotumor cerebri, too much CSF, headache will be your symptom, papilledema will be your sign. Anytime somebody comes in with headache and papilledema, you always got to suspect that they got increased intracranial pressure. Right, Antonia? Right, Bindia? What's the first thing you want to do to rule out increasing intracranial pressure? You ask yourself, what's the worst it can be? A mass pushing down on your brain. How do I rule out a mass, Jeff? How do I rule out you got a mass in your head, man? What about you, Rob? How would you rule out a mass in your brain? It's called a CT scan MRI, folks. That's how I know when they come in with those complaints, CT scan and MRI is your first answer. If you want to get a point, anything else you pick won't get you any. So even though you know it's a pseudotumor cerebri, that's fine, but management for boards 2 is not about knowing what it is. It's how do you manage the patient to make sure they're still alive when you find out what it is. All right? So you always got to say, well, what's the worst it can be? That's what management is. The worst it can be, you better rule that out first before you settle on, oh, it's just pseudotumor cerebri. All right? So you do a CT scan. Well, then you say, what's the next worst it can be? If it's not a mass, it's called an infection. Mayuri, how do you rule out an infection in your brain, Mayuri? Take some of the CSF. What's that called? Lumbar puncture. That's how I know lumbar puncture comes second. Wait before you say, yeah, this is pseudotumor cerebri. This is just management. This is how I integrate it for the boards 2 and 3 people so they understand where that management came from. Otherwise, you just memorizing what some book told you, but if you don't know what order to go in, that's where most of the boards 2 students made their mistakes. They just remember the book saying all these things, but not which one do you do first, which one do you second. Because a lot of times they say, well, you've already done blank and blank. What do you do now? Oh, they lost after that. Okay, they can remember sometimes the first step, but not the second or third or fourth step. All right, so CT scan, lumbar puncture, and then when you do a CT scan on these people, you'll see dilated ventricles. Too much CSF will just dilate your ventricles, Jess. Make sense to you? All right, you won't see any more problems after that. How do you treat them? Serial lumbar punctures. You actually do lumbar puncture after lumbar puncture. But obviously, first of all, you stop the vitamin A that caused the problem. If you know vitamin A caused the problem, stop it. Most of the time, this is a young athlete who thinks 1 vitamin tablet is good, so 3 vitamin tablets must be better. The 2 that I saw, that's exactly what they were doing, taking too many vitamins in the morning until this happened. Now, see, the importance why they're testing you on this is if you don't tell them, guess what? They'll be back in a couple of weeks with the exact same problem again. Nobody told them it was the vitamins that's causing it. Okay, management is always, what's the underlying problem? Take care of that. That's the number one thing you got to do. I mean, stop the vitamin A. Now do the serial lumbar punctures. And the rule is don't take off any more than 30 cc's at a time. Now, Angie, the reason for knowing that number, especially for the boards 2 and 3 people, Katie, is because if you take off more than 30 cc's, you cause osmotic shifts to occur in the brain. You don't want that. You want to take off just enough without osmotic shifts occurring. Because you don't want to tap off. Remember, there's pressure right now. You tap off too much, they'll herniate. All right, but the problem is, and the good thing is, in pseudotumor cerebri, you don't have to worry about herniation because there's nothing pushing on the brain. It's just all CSF. But we're worried about osmolarity shifts. CSF, remember, is continuous with your plasma. The pons, as you're going to find out later, is the most sensitive to osmotic shifts. If you cause osmotic shift to happen too suddenly, you can cause permanent pons damage. We'll be talking about that more when we do sodium. Okay? All right, the main complication of pseudotumor cerebri. What organ comes first in making that determination? Poverty. The brain. So blindness. Number 1. Notice that's neurological. The brain. All right, so this is the one cause of increasing the cranial pressure, Rishi, where we don't have to worry about herniation. You understand, Pratish? Yeah, you understand, Eric? Johnny? Oh, good. Okay, let me finish second row. All right, next to Antonia. To the right of Antonia. Farah? How do you spell that? T-A-R-A. But you pronounce it Farah, like the? Farah. Farah. All right, Farah, got it. Miguel. Farah, Miguel, and? How do you spell that one? Narek. Okay. So Farah, Miguel, Narek. All right, Farah. You understand pseudotumor cerebri now? What's going to be the most common presenting symptom? No, that's a complication. Most common presenting symptom. Yeah, remember anytime you got increase in the cranial pressure, headache is a symptom, papilledema is the sign. Always. Okay? All right. So, pseudotumor cerebri. All right, the other vitamin A connection, now you got too much PTH effect, Jesse. If you have too much vitamin A, PTH works too much. Now, Jesse, what's going to happen to your serum calcium? Huh? Too much parathyroid? Vitamin A is used with PTH, so if you got too much vitamin A, too much PTH to action. So that means your calcium now will go way up. That means, Jesse, your phosphorus will go down. Remember, they got to go in opposite directions. Everybody clear? Right? Ramathia? Cool. So hyperparathyroidism, vitamin A excess. All right. Vitamin B1, thiamine. Thiamine. Thyra. Thiamine, B1. Well, what they want you to know is that it's necessary for 4 very important enzymes in your body. They're dehydrogenases. We're going to be talking about each one of them. Pyruvate dehydrogenase, alpha-ketoglutarate dehydrogenase, branched amino acid dehydrogenase, and even later transketolase. You're going to see these are needed for a lot of pathways, folks. And that's why if you're missing thiamine, all these enzymes just stop working. You understand, Miguel? Understand now, Rick? All right, so you don't want to be thiamine deficient. You understand? All right. Hey, what kind of a person do you know is usually thiamine deficient now, Rick? An alcoholic. That means without thiamine, guess what? Pyruvate dehydrogenase shuts down. Laura, if you got pyruvate dehydrogenase problems, can you enter the Krebs cycle without this enzyme? No. That means everything stays out in the cytoplasm. Oh, wait till we get there. I got to break it down for y'all, man. So you see alcoholism through the eyes of biochemistry. Simple. You understand, Miguel? So B1, thiamine. So thiamine deficiency, first disease, beriberi. What is beriberi, Amika? It means your heart's giving out. Why is your heart giving out, Amika? Because your heart needs all 3 of these enzymes. Your heart needs all 3 of these enzymes. So without it, it just dilates. So they talk about biventricular dilation, just dilated cardiomyopathy. Because again, that means the heart has no energy. Remember, the heart has to keep beating at all times. So beriberi. So we call it dry beriberi until you have heart failure. You got fluid in your lungs. Then we say wet beriberi. That's the only difference. Beriberi. Dilated cardiomyopathy. Because the heart needs all these enzymes. And then Wernicke's encephalopathy. Wernicke's area, Laura, is located in what part of your cortex? Posterior temporal lobe. Correct. So that's why, therefore, Wernicke's encephalopathy is responsible for receiving spoken or written language. If the thiamine is deficient, you cannot understand written or spoken language, and that's what receptive aphasia is. Wernicke's encephalopathy. Receptive aphasia. Now that's to differentiate it from Broca's. B-R-O-C-A. Broca's. That's what we talk about in neuro, which is expressive. That's posterior frontal lobe. Expressive, talking. Remember, they get monosyllabic babbling. All right, expressive aphasia. So Wernicke's, thiamine deficiency, posterior temporal lobe, receptive aphasia. You understand now, Ray? You understand, Miguel? Thyra, you understand? Yeah. Antonio? You understand, Mayuri? Understand, Jen? All right, man. Now, we call it Wernicke-Korsakoff syndrome, Rob, when the mammillary bodies are involved. Because now the mammillary bodies help short-term memory move into long-term memory. So if the mammillary bodies are incapacitated because of thiamine deficiency, you can't remember what you said yesterday. That's what confabulation is all about, Tariq. You start making things up. So, Wernicke's, just a receptive aphasia. Once they say confabulation, it's now into Korsakoff. It means it's gotten more severe. Everybody understand the difference? The key is to know that clue, because everything else is going to be the same. Remember, these are all low energy states. That's why the little clue, folks, is the stuff you better know. The other stuff, we can just fill in the gap. I'm not even worried about that stuff. But if you don't know the clue, then you won't know which best answer to pick on the exam. That's the key. Now it's, oh, was that Wernicke or was that Korsakoff? Oh, yeah. Any, meeny, miny, mo. None of that. All right. So, mammillary bodies have to be involved. They call it Korsakoff. Confabulation is your clue. Vitamin B2, riboflavin. Riboflavin, Raul, is used for cofactors that we're going to be running into, FAD. So that means without riboflavin, FAD can't work. That means the pathways that use it cannot work. You understand, Miguel? That means low energy states because those pathways can't create energy for you. The best source of riboflavin, Nareg, milk. Well, you know, years ago, Nareg, they put riboflavin in the milk. You know how the milkman would come around and set the bottles on the porch, then your mom would come out later on and pick it up, right? And then years gone by, and they saw a huge outbreak of riboflavin deficiency in children. They said, wait a minute, I thought we put riboflavin in milk. Well, they did. The problem is when the sun came out, it actually broke down the riboflavin out of that milk. So the children were drinking riboflavin deficient milk. And how did they know the riboflavin deficiency? Because they all had these little fissures in the corner of their lips. Angular chelosis. Now you've had angular chelosis many times, folks. Okay. Now I know, I don't drink any more milk. blacks and Hispanics become lactose intolerant somewhere between 5 and age 10. So I don't drink milk on a regular basis anymore, unless I got to eat a peanut butter and jelly sandwich. That's the only thing that makes it good, man. You got to have that. I'll bear the pain afterwards just to have peanut butter and jelly. But anyway, the key is, you know, if I don't eat fruits and vegetables, after about 3 or 4 days, boom, fissure, riboflavin deficiency. Did you know? Did you know, Katie? That's why milk is now in cartons. You know what public health is, folks? I'm going to educate you about public health without even reading a book on public health. You know what public health is? Let me just show you the big picture. Is when doctors saw a problem and they lobby with government to make a ruling. That's public health. Rather than reading the public health, why don't you learn the root of that public health? So milk is sold in cartons because sunlight can't get through the carton. See, that's the kind of question that they'll ask you. And you're like, what? Why they ask about milk and cartons on Boris 1? Man, where'd I get that question from? You see, it sounds like a pick. If you knew the root, it'd be an easy question. All right, so riboflavin deficiency, ankylosynostosis. B3, niacin deficiency. So B3 is your niacin. So myuria, niacin, B3, you understand? Well, you need B3 for a lot of cofactors. Look at that, NAD, NADH, NADP, NADPH. A lot of pathways will stop if you didn't have niacin. Not good. And then all the dehydrogenase is needed that we were just talking about. You understand that, myuria? You understand, Antonio? So you don't want to be deficient in niacin because you'd stop way too many pathways. Okay? Well, niacin deficiency, here's your problem. It's called pellagra. So that means Bindia. Bindia, rather. I kind of went over it. Bindia. All right, so pellagra. 4 Ds. You see what the 4 Ds stand for? Diarrhea. Hey, didn't we say diarrhea occurs in lower energy state? Dermatitis. Didn't we say dermatitis occurs in lower energy state? Dementia. Didn't we say you get dementia in lower energy state? And then death. Didn't we say you can die from lower energy state? Oh, my goodness. Well, a long time ago, somebody came up with the 4 Ds for pellagra. Then later on, they found out, heck, every lower energy state gives you the 4 Ds. So anyway, on the boards, humor them, don't argue, don't fight. I sure don't argue. If they mention the 4 Ds, I click pellagra every time. But the reason I'm pointing out to you is, I don't want you to be on teaching rounds, and then the attending asks you, okay, what's your differential for dermatitis? And you say, niacin deficiency. And that's it? No. Every lower energy state gives you that. That means you should be able to give him like 25 of them before he tells you to stop. Okay? So I'm going to teach you guys a lot about survival beyond PASS program. You know, how to survive in front of an attending, whether he's abusive, whether he's nice, or in a big group, small group, all that stuff. I'm going to show you how to survive in all those situations. All right, so pellagra, 4 Ds gives away. And then we got a disease called Hartnup disease, Poverty. Hartnup disease, Jim, that presents just like pellagra. Now, check this out. They're going to say a patient has a pellagra-like disease. Geez, I wonder which one they're talking about. I'm telling you, sometimes the clue is so obvious, your mind just misses it. It says pellagra-like. Well, there's 2 diseases that present just like pellagra. If it ain't pellagra, it must be the other one, Hartnups. Pellagra move, man. Okay? Because they have the same signs and symptoms. The difference is usually what they usually ask on the boards. In Hartnup disease is defective renal transport. They love to ask, where is the actual problem? It's not in the sense of niacin. You can't even reabsorb the tryptophan to make the niacin. That's how you get the exact same problem. All right, cross some Nareg. You got to finish that row. What's that? Jadeep. All right, Jadeep. Jadeep Marina. What is it? How do you spell it? Hovig. All right, Jadeep Marina Kovig. Oh, Hovig. Hovig, and finally, Shelley. Okay. Shelley, Hovig, Marina, Jadeep or Gadeep? The J-A-G? Oh, okay, that's where I'm hearing the G from. All right, Jagdeep. All right, gotcha. All right. So you understand pellagra, Jagdeep? What about you, Marina? What about you, Hovig? Shelley, with me? All right. So they say pellagra-like illness, Shelley, what are you going to pick? Hartnup? Hovig, what's the problem in Hartnups? And what's different about it, though? from where? All right, so defective renal reabsorption of tryptophan. All right, cool. Vitamin B4, lipoic acid. You need it for the 3-dehydrogenases. You need it for the 3-dehydrogenases. You need it for the 3-dehydrogenases, Marina. But there's no deficiency state of lipoic acid. Vitamin B5, pantothenic acid, Marina. You need it for the dehydrogenases as well. So that means, Shelley, B4 and B5, no deficiency state. That means you can eat dirt and get B4 and B5. You can chew on your shirt collar, no problem, B4 and B5. You can lick the bottom of your shoe, no problem, B4 and B5. What this means is there's never been a human being that's diagnosed with these deficiencies. It's in everything you eat. You can eat Twinkies, there it is, B4 and B5 is found in there too. All right? That means you can kiss your honey and get some vitamins. That means you can say, honey, I'm deficient in B4 and B5. Help me out. I'm going to teach you a lot about physio back here, man. All right. All right. Pantothenic acid, however, is used in coenzyme A. So we're going to see that a lot, you know, acetyl-CoA, palmitoyl-CoA. So anytime you hear CoA, they'll ask you about what vitamin is in here. Pantothenic acid is. Okay, you understand, Jack Deep? You understand, Hubik? All right. You understand, Tariq? So, no deficiency state in B4 and B5, Tariq, with me? B6, Tariq, pyridoxine deficiency, man. What do I need pyridoxine for? To make heme. So see, lower energy state, without this guy, you can't even make a heme. Carry oxygen, make ATP. Who else needs it? All the enzymes that end in transaminases. So that means, Katie, when they start asking about ASTs, ALTs, GGTs, see that? They can make it a vitamin question all the way on boards 2 and 3. And then the students have forgotten that stuff because they think, oh, it's just boards 1. I don't think so. All right, there's a drug called INH that pulls vitamin B6 right out of your body. And that's because you need B6 to form the cofactor pyridoxal phosphate. You see that, Laura? Got to have pyridoxal phosphate. Awesome. Pyridoxine deficiency, man, doesn't have anything unique about it. So you need for all transaminases, you need to make heme. Well, every tissue needs it. So that means awesome. If I ask you with a pyridoxine deficiency, what organ are you worried about the most, Osip? Break it down, my boy. Brain. No wonder they say neuropathy is the most common side effect. Gee, where'd they get that from, huh? Folks, that's a default answer. Imagine that. Why don't they never tell you guys that? Anytime they ask you about any drug, anything affecting your body, and you don't know about any clues that I gave you, folks, if you're not sure of something, I told you to default to the Lord and say, if you start guessing, that's how they get you. That's how they get you. Okay? So that means without knowing that valproic acid associated with neurotube defects, I can still get it right anyway. See my point? Still brain, is it not? That's the kind of stuff they never teach you in medical school. Instead, they just teach you, oh, valproic acid causes meningomyelocele. Great. Then what happens when they switch it to some other neurological problem? You say, oh, no, the book didn't say that. See? Now they got you. You lose again. Okay? It's brain. Anything brain, I pick. Okay? So pyridoxine deficiency, neuropathy. Well, you need to know anytime you talk about treating chronic neuropathy, okay, I do my pharmacology in context with physio and biochem, so you see it. If you got to treat chronic neuropathy, drug of choice is a TCA that we'll be talking about called amitriptyline. Amitriptyline for chronic neuropathy. So anytime we have a disease that gives you chronic pain or neuropathy, amitriptyline is the drug you want to use. Oh, I guess I could put it in white, make it easier. If you want to treat shooting neuropathies, Laura, shooting neuropathies, you use what? You remember that one? Let's see if Monica remembers. Shooting neuropathy. Close enough. Carbamazepine. As long as you give me part of it, I'll give you the rest. Carbamazepine is first line, and now we're using gabapentin as second line. It's this again. I always like to do pharm in context with phys and biochem, folks. That's the way you learn your drugs. All right, so we'll be talking about these as just straight pharm when we get to them. But amitriptyline is the drug of choice for just chronic neuropathy. That means no shooting, no stabbing to it. Once they say shooting or stabbing, carbamazepine is your first line, gabapentin is your second line. Okay? So they'll give you a diabetic for chronic neuropathy, and Thara will be all over it, won't you, Thara? So drug of choice for chronic neuropathy, Thara will say amitriptyline. For shooting neuropathy, Antonia will say carbamazepine. All right, good. Vitamin B9. B9. Let's see. Behind Tariq. Let's learn the next row. Victor. And to the right of Victor, Leanne. Victor, Leanne, and Leslie. Victor, Leanne, and Leslie. All right, Victor. B9. Folate. Folate is the first vitamin, Victor, to run out anytime you have rapid cellular division. You understand that? You understand, Victor? You understand, Leanne? Anytime you have rapid cellular division, you're going to run out of folate first. You understand that? You understand that? Leanne? Oh, man. Wait a minute. Don't say anything. Victor, Leanne. Starts with an L. That's all I remember now. Leslie. Leslie. All right, Leslie. So, Leslie. That means any disease you can think of where there's rapid cellular division, I bet you we need to put them on folate. You follow me? Then that means if I could take away folate from cells, what would happen to them, Leslie? It would die, wouldn't it? First cells, first vitamin to run out whenever you have rapid cellular division, folate. You understand, Leslie? You understand, Leanne? Well, Leslie, can you tell me of a state where you got a lot of rapidly dividing cells? Cancer. Cancer is rapidly dividing, isn't it, Leslie? Wow. Hey, you think that's why some of their drugs we use block folate? Dihydrofolate reductase. Why is methotrexate the most commonly used antimetabolite in America? Dihydrofolate reductase. Ring a bell to anybody? What's the best way to stop cells from dividing? Take away their folate, baby. But wait a minute. If you take away the folate from the cancer, you're going to take away the folate from me, too. Everybody follow that? If I'm the cancer patient? Why do you think they say you better give him leucovorin to rescue your patient before he died? Oh, see, that's where management comes from, folks. But if you don't understand the root, you're just memorizing, oh, yeah, give him methotrexate, give him leucovorin. And that's just what the book said. But why did it say that? Because if you take away folate, all cells will stop dividing. Well, what other states can you think of where cells are rapidly dividing, Jim? Cells are rapidly dividing. Okay, so I'll take your first one. I just want to make sure I was understanding. So infections, remember like sulfur drugs? What do they target? Folate. Why do you think they came out with sulfur drugs 30, 40 years ago, way before the other stuff came out? Because if you take away folate, guess what? The bacteria has to stop dividing too. Think about pregnancy. Why do you think they tell a woman who's even thinking about getting pregnant, start your folic acid 3 months before you get pregnant? Folks, right here. That's where management comes from. If you understand the original concept, you can apply it 1,000 times, even though you've never read any article that tells you should give them folate. Poverty, you know of any diseases where you have rapid cellular division? Besides the ones you heard? What about you, Miguel? Any? All right, Thara, you know of any others? Think about diseases like sickle cell anemia, since their bone marrow is always revved up. Why do you think we got them on folate? A little kid with hereditary spherocytosis whose bone marrow is always revved up. Why do you think we got him on folate? A person who got psoriasis, his skin is rapidly dividing all the time. Why do you think we got him on folate? This is what I mean by I can tell you where you need to be using folate. I just think of any disease with a cellular division. And I say, I bet you need folate for this person right here. This way, when the patient's in front of me, boom, it clicks. This person should be on folate. And I ask them, do you take vitamins every morning? Otherwise, I say, you need to be taking multivitamins every morning. That way you get your folic acid. You got to have it. If you don't, you put yourself in trouble. All right? So if you need, if you got folate deficiency, look at that. You need it for THF. That means if you're deficient in it, your nucleotides can't be formed. That means rapidly dividing cells will stop. And that's why when you have folate deficiency, Ramathea, you'll see a megaloblastic anemia, hypersegmented neutrophil. Well, Jesse's probably asking himself, Dr. Francis, how do you get this megaloblastic anemia? Jesse, good question. Well, here's how it happens, man. Let's say, Jesse, I got a cell and a nucleus in the middle. Signal comes, hey, cell divide. Cytoplasm, come on, nucleus, you divide. Hey, man, what'd I tell you? I ain't got no folate. Get off my back. I ain't dividing without any folate. Okay, chump. Signal comes again later. All right, cell divide. Cytoplasm, boom. Nucleus, come on, you divide. Do what I tell you last time. Don't be bothering me no more. I do not divide without any folate. Okay, wuss. Here comes the signal again. All right, cell divide. And then cytoplasm says, okay, see that? Now you got a megaloblastic cell. It says, come on, nucleus, it's time for you to divide. I can't do it, man. Lay on, man. Come on, you can do it, you can do it. Okay. Okay. I can't do it. I can't do it. I can't do it. And stop. When he stops, what do you got? Hypersegmental neutrophils. You know what a hypersegmental neutrophil is? A neutrophil who tried to divide but never could finish. You want to see physio? You better hang with me, baby. That's what I'm telling you. When you can see it, you get, oh my God, you can hear, oh, you'll retain it for life. Instead of just memorizing terms, and then they have no meaning. I always try to connect it back to what started the whole thing. That way everything becomes part of the big picture versus memorizing a list of items. It's hard for the brain to hold on to everything as an item. All right, so megalobacteremia, hypersegmental neutrophils, you say, well, it could be folate, but it also could be B12. All right, but if you see neurotypical defects in the fetus, then you say, okay, it's folate. Most common cause of folate deficiency in America is overcooked vegetables. You understand, Shelley? Did you hear what I just said? Did you hear what I said, Shelley? Did you hear me, Marina? Did you hear what I said? So, Marina, who's more likely to have folate deficiency? Whites or blacks? What do you think? All right, let's say Jagdeep. What do you think? All right, let's say Hovig. What do you think? Okay, blacks, because blacks overcook their foods more than whites. It's a cultural thing. All right, who's more likely to have folate deficiency between blacks and Hispanics? And Angie, you would say? Still blacks. Okay? So that means to me, who's more likely to have folate deficiency between blacks and Asians? Blacks. How about whites and Asians? Whites. Asians stir-fry their food. That's how they cook that stuff. It literally walks off your plate, man. I gotta go chasing it around the doggone restaurant, man. Excuse me, my lobster just walked across your table. Folks, you know what that means? I can tell you that Asians live longer than whites, who live longer than blacks, who live longer than Hispanics, who live longer than blacks. Right there. Now, you can go read epidemiology, or you can see it with me. I saw it right here. That I can put the ethnic groups in order in which they're going to die just from folate deficiency. Can you believe that? Can you believe that? Look at that. That's the stuff I want you guys to be able to see. See that a concept can be applied 1,000 times. As long as you see the concept clearly, you can use it. You can use it to answer a bunch of questions about stuff you never even read. As long as you're going to attach it to that concept. It's, blacks overcook their foods more than anybody else. That's why we die faster than anybody else. Then come Hispanics, then whites, then Asians. So death rate, you go the other way. Check it out for yourself. Folate deficiency, then B12. Cyanocobalamin is B12. B12, necessary for two enzymes. Two enzymes need B12, Victor. One of them is called homocysteine methyltransferase. Hey, wait a minute. You need that enzyme to also make tetrahydrofolate. You understand that, Victor? Well, that means, Victor, if you're missing B12, Victor, isn't that the same thing you can make with folate over here? Do you see that? Do you see that, Victor? Does everybody see that's why you can cover up the anemia of B12 by giving them folate? That's why they tell you when somebody comes with megalobacteremia, check both. Never check one without the other. But if you're going to treat one before the results come back, Jim, which one are you going to treat? The B12. Never just give them folate and then let them go home. Because you can cover up the anemia of B12 deficiency and then they look normal the next time somebody sees them and then they won't do anything. Then they come in later on with the even more severe side effects, dementia. And that's irreversible now. Okay? But I want you to see why the connection. You get the same megalobacteremia, same hyperthermic neutrophils with B12 as you get with folate. The difference is the second enzyme, methylmalonyl-CoA mutase, is necessary in poverty to recycle odd-number carbon fatty acids. That means, Nick, that includes myelin. That's how neuropathy becomes a problem with B12 but not with folate. You understand, Victor? You understand, Tariq? So whenever you see megalobacteremia, hyperthermic neutrophils, the two things to think about, Tariq, are? What two vitamins? B9 and B12. If they mention neuropathy, you then say B12. Well, the two longest pathways in your brain that need myelin, Joni, corticospinal tract and dorsal column. Hey, which two pathways do they usually say affected in your books? Corticospinal tract and dorsal column. They're the two longest pathways, so of course they need the most myelin. It could be any neuropathy, folks. That's the trick to the game. They just give you the most common stuff, you know, I mean, the classic, but that's not. It could be any neuropathy. On the boards, they'll throw in foot drop to try to throw you off. Sural nerve is, who cares? You mention anything neurological, I'm picking B12 every time. Okay? All right, so methylmalonyl-CoA mutase is necessary to recycle odd-number carbon fatty acids like myelin. Okay, the number one cause of B12 deficiency in America today, Tariq, type A gastritis, which is pernicious anemia. Type A gastritis, pernicious anemia. You understand, Leanne? You understand, Leslie? All right. Vitamin C is used for hydroxylation. Vitamin C is used for hydroxylation. You need it for hydroxylating protein and lysine and collagen and some and elastin. Vitamin C happens to be the main antioxidant in your GI tract. Antioxidant, Leslie, means it absorbs free radicals. You understand? Now the question is, what's the number one reason for forming free radicals in your body? Well, number one reason for forming free radicals in your body, Laura, is infection. And the most common infection throughout your body, Monica, is the most common type of infection. No, category. Is it bacteria or virus? Virus more common, remember? CMV 95%. So, viral infection. So that means the problem here, Leslie, is that free radicals don't have any friends. Free radicals are the ones who actually do damage to you when you have the infection. They destroy tissue. Everybody with me so far? So that means the number one reason for liberating free radicals to damage your tissue and make you feel ill is a virus. You understand, Leslie? Now, what vitamin do they tell people to take if you want to fight the common cold? I could have sworn it's vitamin C, wasn't it? I think I know the connection now. Everybody see it? All you're doing is absorbing the free radicals that 95% of the time the virus is in your system liberating. And guess what? You don't get ill from it anymore. The virus is still in your system, but you're not ill. That's the difference. That's what vitamin C is all about. That's what drinking orange juice in the morning is all about, especially on a cold day. See that? Make sure you got plenty of vitamin C running through your system. Why do you think they got it in Hawaiian Punch, since kids love Hawaiian Punch? Why do you think they got it in Sunny D? Why? Because kids love Sunny D. Why do you think they keep putting it in that stuff? To fight viruses. Because that's the most common infection you have in your bloodstream at any given moment. Okay? So vitamin C. The way they'll make it up, boys, 2 or 3 question is you need to give somebody iron. Iron, if it gets oxidized, is useless. That means if free radicals attack it, it's no good anymore. They'll ask you, gee, what vitamin would you give them to protect the iron you just gave them, Ramathea? Vitamin C, that's why they say give iron supplementation with orange juice. See, but by the time you read it in the article, they just say give it with orange juice, but they don't tell you the reason why. The key is if you don't understand that, then you think it's about the orange juice. Well, if they got orange juice in the house, what are you going to do now? Any juice. Any juice has vitamin C in it, so who cares whether it's orange or pineapple or anything else? That's the key. It's the vitamin C, not just orange juice. All right, so that's vitamin C. Vitamin C deficiency, we call it scurvy. Scurvy, Leanne. Classic clue, you're bleeding from the hair follicles and gums. You start bleeding from hair follicles and gums. All I got to do is think about the pirates. You notice their gums are bad and they're bleeding from hair follicles. They had all these little blood blisters all over their skin. Classic scurvy. Why? There are no fruits out on the high seas. So they couldn't get any vitamin C out there. Okay? Vitamin C deficiency. Any questions so far? Okay? Vitamin D is necessary for bone and teeth formation. Bone and teeth over here behind my earring. Let me start on your row. What is it? Malik. And after Malik, what? Naseet. How do you spell that? N-I-S. S, wait a minute. N-I-S-I-S-I-T. Naseet. Okay, Naseet. All right, so every time I start concentrating on Indian names, I forget the last guy who talked to me. All right, wait a minute. What was your first name again? Malik. All right, Malik, Naseet, Marcelo, Naseet, Malik, Naseet, Marcelo. Okay, let me try those. All right, Malik, you understand vitamin D? Necessary for teeth and bone development. So vitamin D will stimulate osteoblastic activity. Whereas remember, PTA stimulated osteoclastic activity because you're breaking down bone. Now, I'll warn you, even though in your books they talk about, oh, if you stimulate this, if you stimulate osteoclast, you also stimulate osteoblast. On the exam, folks, you better know which one cell to pick. All right? The net result of PTA is to break down bone, so you got to pick osteoclastic activity. Even though your book mentioned osteoblast, you won't get your point. I'm just telling you. Okay? Same thing with vitamin D. Net result, vitamin D is osteoblastic activity. So on an exam, you pick osteoblastic activity, even though osteoclasts are also activated. Don't pick it on an exam. Okay? All right. So osteoblast, osteoclast. So vitamin D is osteoblastic activity. That's because you need to build bone. You need osteoblast to build that bone. And therefore, you need calcium and phosphorus. And that's how you know with vitamin D, both go in the same direction. When calcium and phosphorus go in opposite directions, Antonia, what do you think about? What hormone are we going to blame it on? PTH. Who needs what vitamin as a cofactor? Vitamin A. Vitamin A. That's all right. All right, vitamin D is responsible for mineralizing your bones and teeth. Okay? So vitamin D will stimulate osteoblastic activity, stimulate calcium and phosphorus reabsorption from the kidney and the GI tract so that you can put it into the bone. You understand this? You understand Malik? And, oh man, what's that? Marcelo. All right, Marcelo. Where you from, Marcelo? San Antonio. Marcelo from Antonio. I like that, man. Got that sexy, Antonio. I am Marcelo from San Antonio. You got a killer rap just saying your name, man. All right, so vitamin D mineralizes your bones and teeth. What about vitamin D deficiency, Marcelo? In children, we call it rickets. That's bowing of the legs, lateral bowing of the legs. Now, don't get it mixed up with anterior bowing of the legs. That's an infection. Monica, anterior bowing of the legs. What infection is that? What infection? You just mentioned something that's not even an infection. Remember I said, if you say something out of context, I'll warn you just so that you catch this habit. You don't realize how it's a habit of the brain to do that, just so you know. That's why I'm pointing out to you. The best way to get rid of a habit is to be aware of it. Once you're aware of it, the habit starts to die down. Okay? Let's see if Laura remembers. Anterior bowing of the legs. What infection do you think about? That one is, do you know that? Yeah, syphilis. Syphilis does anterior bowing. I just want to make sure nobody misheard me. Lateral bowing is rickets, anterior bowing, syphilis. Okay? So we'll talk about that in micro. So rickets, lateral bowing of the legs. In adults, we call it osteomalacia, Angie, which literally just means soft bone. You understand? Poverty. You understand? Shweta. Soft bone, osteomalacia. All right, then there's a disease called vitamin D-resistant rickets. This is one of two X-linked dominant diseases. One of two X-linked dominant diseases. How do I know you got an X-linked dominant disease? The only way to be absolutely sure, dad has it, gives it to all his daughters. Remember, he's got to give his X to every daughter, right? That's the only way to be absolutely sure. Otherwise, you have to wait several generations to actually see it going from mom to the boys, and then you also see it getting to the girls as well. And now you say it's X-linked dominant. Okay? But if they mention dad give it to all his girls, now I'm sure. Click and move. X-linked dominant, the two you need to know. Vitamin D resistant rickets and then pyruvate dehydrogenase deficiency. Okay? Only two diseases, X-linked dominant. Okay? The problem in vitamin D resistant rickets, Monica, the kidney is having a hard time reabsorbing phosphorus, so the phosphorus is leaking out and dragging calcium with it. And that's why when you see them, Malik, it looks like they're vitamin D deficient because calcium and phosphorus are both low. Make sense, Leanne? Make sense, Jim? Yeah, but then when you give them vitamin D, nothing happens. That's why they call it vitamin D resistant rickets. That's because no matter how much vitamin D you give them, they still cannot reabsorb phosphorus because it's not a calcium problem, it's a phosphorus problem. Okay? Vitamin D resistant rickets. Now, light up on there's a survey that went out years ago that said that women think that bow-legged men are much more sexy than straight-legged men. So every month, I always like to take a little survey and find out how many of you filled out that survey. Let's see. We're going to start in the back this time. All right, in the back. What is your first name? Yeah. No. In the back. The females. Yes. Martha? Ooh, Lord. What'd you say? How do you spell it? Oh, Margara. Ah, okay, Margara. You think bow-legged men are more sexy? Nah. Name next to Margara. What? Who? Jennifer. Bow-legged men more sexy to you? No, she says, in front of Jennifer. Janice, bow-legged men more sexy to you? No, she says, to the right of Jennifer. Janice, to the right of Janice. What? Anna, bow-legged men more sexy to you? Anna says no. I to the right of Anna. Johanna, bow-legged men more sexy to you? No, she says. Katie, bow-legged men more sexy to you? Oh, yeah. Prathy, bow-legged men more sexy to you? No. Leanne, bow-legged men more sexy to you? Oh, depends on why he's bow-legged. Allow me to break it down. What Leanne is really trying to tell you, because a female finally gave out the secrets. The reason why women think bow-legged men are much more sexy is because they have this vision of why he's sagging a little bit in the middle there. All right, folks. Now, let me tell you something. Hey, folks, it's not my research. My job is to educate you. Look at that. You know what? It's like the most queasy people about sex go into medicine for some doggone reason. Anything about sexuality, medical students and doctors all get all queasy about it. I always tell students, become comfortable with your own sexuality because you got to deal with strangers about theirs. If you're uncomfortable with yours, it becomes obvious in the conversation. They'll shut up and won't ever talk about it anymore. All right? So, the research said 95% of women, there's a difference between what women, or anybody for that reason, say when they're out in public, i.e. now, versus when you slide a questionnaire underneath the door and they can be truthful. You see that? Almost the majority say, yeah, bow-legged men are much more sexy. Well, men were surveyed as well. Same thing. What do you think about bow-legged men? Bow-legged men, now men thought they were more masculine and powerful. You know, power. Now, you may not know that this is, they do a lot of research to figure out what's in your subconscious, because when you ask somebody to talk about something, the conscious comes out, they lie. Okay? Yeah, so I already know most of you are lying. All right? If you think that's not true, next time you go by a magazine stand, look at the comic books and tell me why is Spider-Man bow-legged? Why is Batman bow-legged? Why is Superman bow-legged? Why is Captain America bow-legged? Why is the Hulk with his green ass bow-legged? Folks, they're trying to attract both sexes. You guys don't even know that. They want both sexes buying those comic books because women are attracted to the strength of the the sexiness of the bow-legged man. Men are attracted to the strength of a bow-legged man. Look at the movie that just made $100 million over the weekend, Iron Man, and explain to me why he's bow-legged too. Right. You think just the guys went to see that movie? Oh, no. You know that wrestling had the top 7 out of 10 shows on television at one time? I don't know if they got all, 7 out of 10 now, but for a while there, they were just dominating everywhere. That's where all these wrestling shows came out of. Okay? You know who the most popular villains were on there? The bow-legged ones. Go back and look, folks. The women were the biggest audience. You think it was just about men? I don't think so. The women said they love bow-legged men. And then women say, tell you what, we want to check out their buns too. So they say, put them Speedo shorts on them. Them tight shorts on them. It was the women who drove that. It was the women who requested that because they want to see the butt. See? Yeah, but when you get women in public, then they start pretending. Nah, I don't like that. And then get them alone. Oh, yeah. All right, so anyway, vitamin D deficiency. Vitamin E is the main antioxidant in your bloodstream. So that means, Malik, anytime you got free radicals in your bloodstream, vitamin E is the one that can absorb it for you. You understand that? Anytime you got free radicals in your GI tract, who absorbs it for you, Malik? Who? In your GI tract, Malik was my question. Naseet, tell him. Vitamin C absorbs free radicals out of your GI tract. Vitamin E absorbs out of your blood. You understand the two questions? All right, so you understand, Leanne? All right, so, Leanne, what's the number one reason for having free radicals in your bloodstream? Infection due to what, Leanne? Thank you, Leanne. She got that pattern down already. See that? That's what patterns are. It allows you not to have to rethink. Just come up with the same connection. I bet you the answer is still the same. All right, so this way, why, when we get to, what's the number one reason for hemolytic anemia and G6PD? Infection. What's the number one reason for DKA? Infection. What's the number one reason for hemolytic crisis and sickle cell anemia? Infection. Folks, you're going to see it over and over again. It's the same concept if you see this. Because free radicals are what's setting them off. Free radicals cause, oxidation of your RBCs. Well, that's what G6PD is all about. Now you can't repair. Free radicals suck up your oxygen, and then you sickle. That's why that's the most common reason. Oh, my God. Free radicals, number one reason, virus. And that's a stress to the body for a child, and now he can't turn off ketogenesis, DKA. Same old stuff. Same old stuff. Vitamin E. So, diseases involving oxidation, big ones, cancer. That's why we give vitamin E to cancer patients. Alzheimer's, vitamin E is being given to them. Coronary artery disease, vitamin E. We always tell them to take vitamins anyway, all the vitamins. So now we got folate, vitamin E. As you can see, are very important. You got cancer. And then G6PD, you got hemolytic anemia. The main antioxidants, just to summarize it. In the blood, say E. In the GI, say C. And then vitamin A and beta carotene are some other ones. And then their trace elements are minor antioxidants when we talk about it. Biotin is necessary for carboxylation. Naseet. For carboxylation, well, that means there's a lot of carboxylases out there. And so that means any organ can be affected. But if you have to pick one organ on the boards, Naseet, which one are you going to be picking? Naseet, which one are you going to be picking? Who? Marcelo, remind him. Oh, yeah, the brain. What are you going to pick after that, Naseet? What if brain's not on the list? What are you going to pick now? The heart. What if heart's not on the list, Naseet? The kidney. Don't forget, folks. Because this one has nothing specific, so there's nothing for me to tell you. We're going to be doing a lot of carboxylations. We'll do biochemistry, so they can go for fatty acids, or they can go for gluconeogenesis, I don't know. But the key is, if they ask me complications, I'm going for neuro first, cardiac second, renal third. And it'll still be the right answer. All right? So that's biotin. Vitamin K is needed for gamma carboxylation. Now, what is gamma carboxylation? Marcelo is asking himself. Gamma carboxylation. Well, the vitamin K dependent factors already have 1, 2 carboxyl groups on them. Alpha, beta. That means if you add a third one, gamma. That's what we mean by gamma carboxylation, adding a third carboxyl group on. Well, more than that, let's understand this. Each one of these vitamin K factors, 10, 9, 7, 2, protein CNS, have actually 10 glutamic acids on their carboxy terminal. That's the one over to the right. 10 glutamic acids. Janice, right? All right, 10 glutamic acids on the carboxy terminal. And 10 glutamic acids already have 2 carboxyl groups. That's 20, right? So 20 negative charges. And then I'm going to add a third one. So that means now there's 30 negative charges. You understand, Janet? You understand, Anna? You understand, Joanna? All right. So that way, if I had all these negative charges on these vitamin K factors, what am I doing that for, Bindia? Is because it's got to be attracted to a lot of positive charges. Well, when you learn clotting, don't platelets release calcium on their surface to start the clot? Well, now you know how they attract the vitamin K factors over there. Oh, that's what happens. Well, that means if I give you a drug that blocks vitamin K, Asif, like warfarin, Coumadin, that means I'm going to block all 6 of these. 10972. Just remember the year, 1972. And then protein CNS. Everybody follow me? Everybody follow that statement? Well, Anna, of those 6 factors that I just gave you, protein C has the shortest half-life. Which means, who's going to disappear first, Anna? Protein C. Everybody clear about that? The problem, Anna, is that protein C is not a clotting factor. It's the first thrombolytic to show up to protect you. Uh-oh, we got a problem. That means, Joanna, if I give you warfarin or Coumadin and block your vitamin K, of the vitamin K factors, which one will disappear first? Protein C. And protein C is a thrombolytic, the first one to show up to protect me. So now I'm going to disable him. If I disable a thrombolytic, am I going to be more or less likely to form a clot? Huh? You're disabling a thrombolytic, the guy who breaks down the clot. So that means now you're more likely to form a clot. You understand that? You understand, Janet? You understand, Jennifer? The problem, Margara, is that if I give you warfarin or Coumadin, protein C has a half-life of only 6 hours. 6 hours, Sharice. How many half-lives do you need to reach steady state? Sharice? 4 to... No, that's all right. Let me teach it to you. That's all right. Remember, whenever I ask you a question, I don't expect you to always be right. I'm going to show you how to be right so that you know it next time. All right? It's 4 to 5 half-lives. Remember, it's like 50%, 75, 84, 95, 99. So that's why 5 half-lives. So if I tell you the half-life is 6 hours, how many hours to reach steady state? No, you take 5 times 6 half-lives. I mean, 6 hours, right? And what is that? What do you get? 5 times 6. 30. That means after 30 hours, all the protein C is gone. You understand? Okay. The problem is, starting at 6 hours, however, Nick, you just knocked out 50% of my protein C. That means I can now form clots. And yet you gave me a drug to stop me from forming clots. Do you understand me? That's the reason why you need some other drug to protect you starting at 6 hours, Nick. When you give somebody warfarin, that's the reason why we always give heparin before the warfarin. And by understanding that, folks, then I don't forget that you got to give heparin before warfarin. Otherwise, one day you might forget and give warfarin before the heparin. You do that, you get one last warning. The person always necroses a piece of skin first. Somebody with protein C deficiency, and you accidentally give them the warfarin before you give them the heparin, they're going to necrose off a piece of skin. That's your last warning. But here's the problem, Tariq. Let's say I, the doctor, don't understand what's going on, and you put the patient on warfarin 2 days ago, and they come in to see me in the emergency room, and I see evidence of clotting. You see how natural the response is, give him more warfarin? You need to anticoagulate him some more, which means he can now stroke out and die before anybody knows what's going on. Okay? Your last warning for protein C deficiency. Well, it turns out, Amika, that factor 7, remember 10972, the first actual clotting factor, factor 7 has the shortest half-life of the clotting factors, 10972. Factor 7 has a half-life of 2 days. If factor 7 has a half-life of 2 days, Sharice, how many days to reach steady state? That's okay. How many half-lives to reach steady state? What was the number I gave you? 5. And I told you the half-life is 2 days. So how many days to reach steady state? 5 times 2 is what again? 10. That's how long I know you have to stay in the hospital on heparin till you are now therapeutic on warfarin. Now I can stop the heparin and send you home. You understand? So it translates to the therapeutics for divorce 2 and 3 management. How long they gonna have to stay in the hospital? That's how long. Okay? So if you put them on warfarin, you got to make sure you put them on heparin first, because starting at 6 hours, they are more likely to form a clot. You understand that, Laura? You understand that, Bindia? Or Bindia? Bindia, right? I just keep saying Bindia. All right, Bindia. All right, you understand, Jim? You understand, Leslie? You understand, Katie? All right, you understand, Prethi? All right, you understand, to the left of Prethi? Rick, you understand, Rick? You understand, what's your name? What? Lee? Dude, spell it for me. Who? What? Oh, K-Y. K-Y. Whoa, okay. I'm going to have to ask you a couple of times anytime I ask you a question, man. Don't be offended now. I got to make sure I understand what you're saying. But K-Y, Key. Okay, now I remember seeing that. All right, Rick, Key. You understand, Rick? You understand, Key? All right, so anytime you give somebody warfarin, you must give heparin first. Everybody clear about that? Because at 6 hours, you knock out protein C. That leaves me naked to form clot if I already have a genetic protein C deficiency. That's the key. But you get one last warning. They'll necrose off a chunk of skin. If you don't stop that warfarin, you're going to kill them with the warfarin. Everybody understand that? That's the irony. It's a paradoxical effect. You give them warfarin and now they die of clots. But you don't understand why. Unless you understand this. Okay? All right. So warfarin is a competitive inhibitor of vitamin K or Coumadin, whichever form you want to. Given orally. Again, always give heparin first because warfarin crosses the placenta. So if the woman gets pregnant, the baby's going to bleed to death now. So we don't like that. Plus, warfarin is teratogenic to the fetus. Okay? Follow the prothrombin time. Why? Prothrombin time is for the extrinsic pathway where factor 7 is located. That's how to remember that. Remember, extrinsic pathway is tissue factor plus factor 7. So if you knock out 7, PT elevates. Now, PTT will elevate later, but PT is the one we're going to follow because it elevates first. The INR you're shooting for, that means how many times normal? 2 to 3 times normal. What does that translate into, Z? It means you are 2 to 3 times less likely to form a clot. You understand? It means it would take you 2 to 3 times as long, Z, to form a normal clot now. You understand that? So, 2 different ways to interpret the same number. Okay? All right. So, they found if you do more than 3, well, then you got more bleeding and hemorrhages. That defeats the purpose. So, that's warfarin. If you give somebody warfarin and the PT goes too high, Shane, and you want to reverse it, just give him vitamin KIM. Do you understand, Shane? All right. Rahul, if you give him warfarin, but they're bleeding all over your floor and you want to stop that bleeding right away, give him fresh frozen plasma. Because FFP has all the clotting factors in it. You understand, Miguel? You understand, Thara? You understand, Antonia? You understand, Mayuri? Cool. Pretty good. I got half the class done already. Yeah, all right. All right. You understand the reg? All right, man. So heparin is a cofactor for antithrombin 3. This is why you must start it first. That way it activates antithrombin 3, Miguel. So now you have another protection against clots. You understand, Angie? Because, remember, protein C can't help you anymore. Then you got to activate the other one. You understand? Bindia? To the right of Bindia. First name. What is that? Jose? H-O-S-E-A? Oh, okay, H-O-S-E. All right, Jose. You understand, then, with heparin. You give heparin first to activate antithrombin 3. That way, antithrombin 3 now protects you from clots starting at 6 hours. Heparin has a half-life of 6 hours. Look how well that coordinates, folks. At the very minute you're naked because of protein C, I got antithrombin 3 protecting you now. Okay? Heparin before warfarin. Okay? And then, of course, as Sharice now clearly understands, after 5 half-lives, 10 days, now you can stop the heparin and send them home on warfarin. Okay? Following the PT. The problem is with heparin, or rather the difference with heparin, you follow intrinsic pattern, PTT. Again, you're shooting for INR 2 to 3 times normal. If you give them too much warfarin, the PTT is too high, Shane, reverse it with a drug called protamine sulfate. Which lets you know, Janice, that heparin is charged or uncharged. Which one? Charged. Sulfate is charged. That means heparin better be charged too. And that's how to remember, Janice, why we use heparin only in pregnant women. Because it doesn't cross the percent if it's got that much charge on it. If you give somebody heparin, you follow PTT. Let's say you give somebody heparin. Now I'm going to give you all the complications of when you're on heparin. All right? It goes like this. If I give you heparin and you throw another PE. Let's say you come in with a PE and I put you on heparin, and then while you're on heparin, you throw another PE. That means the heparin's not going to protect you. Laura, what do I do for you now? You're on heparin, and you throw another PE anyway. It means the heparin is not going to help you. Let's see if Monica remembers what you're supposed to do. All right, that's when you put in a IVC filter. You put in a filter in the feeder vena cava. It's like a little umbrella. That way any clots that come out get caught in the umbrella and no more goes up to the lung. Because if you're lucky enough to survive 2 PEs, the third one's probably going to kill you. So that's why we got to do something drastic. All right, so somebody on heparin, and they throw a second PE filter. It means the heparin is not going to be enough. Okay? When you put somebody on heparin and switch to warfarin, they have to stay on warfarin minimum 6 months, and then you reevaluate. So duration of therapy is automatically 6 months before we reevaluate. Which means, Jose, if you know why they formed that clot, you can stop the Coumadin. Like a truck driver or somebody flew in a transatlantic flight, you know why they made that clot. Well, they're not flying every day, so we don't have to worry about it. So you stop the warfarin after 6 months. If you don't know why they formed that clot, then you have to continue warfarin for the rest of their life. Does that mean they can form another one? The most common reason for forming clots spontaneously is something called factor V Leiden deficiency. Now, you'll go through all the clotting disorders when we do clotting this Saturday, but I just want you to know the 90%. Every time we do something, I want you to know the 90%. That way, if I ever ask you, or if you're ever asked on a test question, folks, you should spit out the 90% first before anything else. Okay? So heparin. Now, if they're pregnant, they have to stay on heparin only. There's no other choice. You have to stay on heparin. Okay? Most common complication with heparin use, bleeding. Just like any other thrombolytic, right, Katie? Makes sense to you? Bleeding is number 1 complication. Number 2 problem to worry about is that heparin can activate what they call lipoprotein, hormone-sensitive lipase can be activated by heparin and mobilize lipids. So you get hyperlipidemia as a side effect. So in case they ask you why do your lipids go up with heparin infusion, that's the reason. Heparin can activate an enzyme called hormone-sensitive lipase, the same one glucagon activates. Okay? And then third complication to worry about, heparin can act as a hapten on platelets. This is what that heparin-induced thrombocytopenia you hear a lot about, is the physiology to it. Heparin can sit on top of a platelet, making it look foreign. That means your body has to make antibodies against it now. Heparin-induced thrombocytopenia. So 3 main side effects to worry about. Now, Laura, if you want to decrease the incidence of side effects with heparin, then you switch to what? Low molecular weight heparin. That's the indication for low molecular weight heparin. They do the same thing. Question is, when do I switch to decrease side effects? So if they already had problems in the past, then that's how you know. Switch to low molecular weight. Most places use low molecular weight now. Hardly anybody uses the regular unfractionated heparin. Okay? What if they've had a history of heparin-induced thrombocytopenia? Then you switch to a drug called what, Laura? Agatroban. Something totally unrelated to heparin. This is in people who have had heparin-induced thrombocytopenia, Leanne. Not just they had side effect. It has to be just that side effect. The problem is that's a systemic disease. So you can't use anything that reminds the body of heparin. So that means even low molecular weight can set it off. It's just a lower risk, but it can still set it off. So we use this drug, Agatroban, which blocks thrombin. So it's totally unrelated to heparin. So a patient with a past history of heparin-induced thrombocytopenia, I know that's where they're going. They want this answer. Okay? All right. Bleeding number one, hyperlipidemia, because it activates hormone-sensitive lipase, and then heparin-induced thrombocytopenia. Okay? What are your germs good for? They make 90% of your vitamin K. They also make biotin, folate, pantothenic acid, and they help you absorb B12. So that means, Malik, you need your gut flora to make these, to help you with these vitamins. Well, Malik, if you don't have any gut flora, which one of those vitamins would you miss out on the most? Vitamin K. Does everybody see that? It says they make 90% of it for you. Well, listen, think to yourself and ask yourself, when in your lifetime did you not have many gut flora in your GI tract? When you're first born. Wait a minute. Could that be why we give vitamin KIM to all newborns in America? Let me think. Sounds like management to me. See that? You give them one shot of vitamin K, it lasts for 6 to 9 months. By that time, they've sucked enough germs off of mama's nipple. Now they can make their own vitamin K. All right? But the way they'll try to get you on the boards, Shelly, is they'll give you a teenager who was on a cab ride on the way to some friend's house and then delivered the baby in the cab. Well, last I checked, cab drivers don't carry vitamin KIM in their back pocket. And that means if you're not reading that carefully, you won't realize nobody gave that baby vitamin K. And then when they go home, 2 days later, the baby starts bleeding to death, and they're going to actually explain why. In Africa, it happens all the time, folks. They don't have vitamin KIM in Africa. Poor countries. America, no problem. But in poor countries, they don't have it. A lot of babies go home and bleed to death 2 days later. Why? Factor 7, I just told you, the half-life of 2 days. Once it starts to disappear, they start bleeding. Okay? So vitamin K. Then you got biotin, folate, pantothenic acid. But notice they help you absorb B12, Joni. They don't make B12. They help you absorb it. You understand? Yeah, be careful when they say, well, which one does it make? Hey, wait a minute, Joni. That means if I kill off too much of your normal flora, you start bleeding, won't you? Why is that? Because you can't make 90% of vitamin K. Oh, wait a minute. Maybe that's how broad-spectrum antibiotics cause bleeding. Ooh, I think so. See, so they'll give you a patient who went to surgery, you put him on preoperative antibiotics, and then, of course, 2 days later, 2 days again, see that? Now he's bleeding all over the place. You can actually explain it. Probably that antibiotic you gave him, you've killed off too much of the normal flora now. Okay? In babies, we call it hemorrhagic disease of the newborn. Okay, and when we talk about the cephalosporins, you'll see the 4 cephalosporins who cause so much bleeding because they block vitamin K. All right. Minerals. Calcium, magnesium, zinc, copper, and iron. Minerals. Here's what we need calcium for. We need calcium more than any other mineral. Intracellular calcium is needed for all muscle contractions. So we're going to see that in neuromuscular phys. Intracellular calcium, key. Not extracellular. Intracellular calcium is necessary for contraction. You understand? All right? Smooth muscle needs extracellular calcium to trigger off its second messenger systems. So we need calcium for that. The atrium, Rick, is the only membrane that needs calcium to depolarize. That's depolarization. Calcium to depolarize. Okay? And then the cardiac ventricle, Janice, depends on extracellular calcium to trigger off intracellular calcium release. You understand? All right. So calcium, we need a lot of it. And that's why, for a non-pregnant woman, Janice, a non-pregnant woman needs about 1,000 milligrams of calcium a day. And that's 2 to 3 glasses of milk. That's why the milk industry would rather you get it that way. So they got milk commercials. Of course, Tums would rather you eat Tums to get your calcium that way. And that's something I need for my body anyway. Okay? You see? Everybody's trying to get to market, okay? Because you got to have the calcium. You can take it any way you want. But 1,000 milligrams if you're not pregnant, 1,500 milligrams if you are. Because look at that. You need calcium for axonal transport. That baby's going to be retarded if you don't have no calcium in that pregnant woman. Look at that. Presynaptic influx of calcium is necessary for release of all neurotransmitters. More mental retardation without calcium to release neurotransmitters. And then calcium is necessary for bone and teeth development. So bad problems if a pregnant mama does not eat enough calcium. You understand, Angie? You understand, Miguel? Narek with me? Check, dude. Marina. Hovik. Shelly. All right. I got a patient who's got night blindness. Shelly, what's his problem? Vitamin A deficiency. What if he's got lateral bowing of his legs? What's his problem, Shelley? Not syphilis. Students always give me all these things that it's not. I always say, skip the long story. Just tell me what it is. All these other things. It's not, well, I know it's not. It's not that. It's not that. It's not that. It's not that. You're praying the whole time. You're telling me all that. Rishi, lateral bone of the leg. Rickets, vitamin D deficiency. All right. Magnesium is a cofactor for all kinases, Monica. What do kinases do, Monica? What do they do, Gretchen, you know? Kinases phosphorylate a bunch of things. But they produce ATP, that's the thing. That means if you take away my magnesium, all my, literally 90% of my ATP production stops. This is the favorite question of anesthesiologists. They say, well, if you're going to check one mineral before you put somebody under anesthesia, which one are you going to check? Folks, think about it. How do they wake up? If you put them under, they got no magnesium. They die under anesthesia. That's one of their favorite questions. If ever you do an anesthesiology rotation, they ask you the one mineral you want to check before you ever put anybody under. You got to have ATP to wake up. And if they're hypomagnesiemic and then you knock them out, all the kinases stop working while they're out. That means they can't wake up. Not good. Okay? All right, magnesium is also a cofactor for PTH, along with what vitamin, Shelley? Magnesium is a cofactor for PTH, along with what vitamin? Joseph knows. Vitamin A. So now you got one mineral, one vitamin, cofactor for PTH. Magnesium interacts with potassium as well. So by way of PTH, when magnesium is low, calcium is low, magnesium is high, PTH, calcium is high. Everybody understand this? Anytime you got a problem with calcium, they always say check magnesium and vice versa, because they're related by way of PTH. If one goes down, the other one's coming down too. Okay, this is why, like in the ICU, we always check calcium and magnesium together. We don't check one without the other. Okay? So on the boards, the way they try to get slick is they tell you got a patient who's got low calcium, and you give him calcium gluconate, and then 2 hours later, his calcium drops again. It means his magnesium is still too low, but you need to correct that, or else this one will never stay normal. Okay? Well, magnesium and potassium have the same yo-yo role because of the distal convoluted tubule. If your magnesium is low, your potassium will go low, and vice versa. Magnesium is high, potassium will go high too. It's a protein in the distal convoluted tubule. So right now, at least we know where it is. Before we didn't even know where it's at. Now we know where it's at, but somebody's got to, do some more research to figure out exactly how it's occurring. Right now, all they're going to ask you is what electrolytes can be affected whenever you got a magnesium problem. Calcium and potassium. Okay? Zinc is necessary for hair, skin, sperm, and taste buds. But the most unique function, Tariq, is the taste buds. So you get dysgeusia. Dysgeusia, Jagdeep. Dysgeusia. Anytime you hear dysgeusia, think zinc. You understand, Eric? You understand, Joni? Dysgeusia. That means abnormal tasting. Okay? Zinc deficiency. Copper. It's necessary acid for lysine hydroxylase. Hey, what other vitamin do you need to hydroxylate lysine? Acid. Vitamin C. So you need one vitamin, one mineral. All right, copper hydroxylate lysine in the formation of collagen. All right, copper is also needed in complex 4 of electron transport system. So that shuts down ATP synthesis if you don't have that. With copper excess, it's called Wilson's disease, Shane. Wilson's disease is autosomal recessive. So here's our second genetic pattern, autosomal recessive. Big A, small a times big A, small a. Here's all the combinations. One of these, two of these, one of these. That means, Shane, what's the chance of being small a, small a? Always 25% chance of getting the disease when there's a family history. Everybody clear on that? If they ask you what's the chance of getting that disease, that's autosomal recessive, the answer is always 25%. Then the next question they ask, what's the chance of being a carrier? The definition of a carrier, Shane, says you got to look normal first. Well, 3 people look normal. How many of them are actually carrying the gene? There's 3 people left, Shane. How many are actually carrying the gene? 2 of the remaining 3, so 67% chance of being a carrier. A lot of students pick 50%, just like you heard it blurred out. That's a mistake. The old definition got lost in a lot of books. They don't explain this to you. If you say the word carrier, you got to first look normal. Small a never looks normal, so you can include him in that. Okay, so there are only 3 people left and only 2 carry the gene, so 67% chance. Very commonly missed question. That's for autosomal recessive when there's a family history. If there is no family history, you got to use the Hardy-Weinberg equation, where big A is P squared. 2 of these is 2PQ plus Q squared equals 1. That just means all the combinations you can get. Everybody following that so far? Anybody not follow that? It's just, Hardy-Weinberg just says all the combinations you can get from small a, big A, small a. All right? Well, they give you Q squared, because that's the incidence in the general population. I just go out there and count it. You know, 1 in 2,500. That's what they'll tell you. They just make up a number. If 1 in 2,500 equals Q squared, the instance of the disease, what's the frequency of the gene? Just take the square root of that. I would say, what's the square root of 1 over 2,500? What's the square root of 1? 1. Square root of 2,500? 50. Yeah, 5 times 5 is 25, right? So 50. So 1 over 50, therefore, equals Q. So that's all they want, frequency of the gene. I say, oh, 1 over 50. But if they want the carrier state, then that's 2Q. So it's 1 over 50 times 2, which is 2 over 50 or 1 over 25. So that's how you use Hardy-Weinberg equation to figure out the frequency of the gene and then derive the carrier state. This is when there's no family history. The minute they mention a family history, Jennifer, then you say the chance of getting the disease is what? You know, so recessive, you say what? 25%. Margaret, the chance of being a carrier in autosomal recessive when there's a family history is what? What? 67%. Everybody clear about that? Read the vignette carefully. Is there family history already said, or do they want me to just use Hardy-Weinberg equation? All right. So, Wilson's disease. The problem here is ceruloplasmin is deficient. So a protein deficiency starts this whole thing. You understand, Malik? All right, then copper is free to just float around now, Reg, and just deposit wherever it feels like it. The problem is it gets deposited in the basal ganglia. That's why they get movement disorders. Then Jesse gets deposited into your iris. So you get this orange ring around your pupil, Kaiser-Fleischer rings. And then it gets deposited, Angie, into the liver, and that's how you get cirrhosis. So that's why they call it hepatolenticular degeneration, Wilson's disease. Then you can bind up the copper by giving a drug called penicillamine, Joni. So just bind the copper and pull it right out. So Wilson's disease. Wilson's disease is one of the causes of movement disorders in middle-aged people. So let's look at copper deficiency. When you don't have the copper, I don't think this one printed out for you guys, did it? I think I added it late and it just didn't print out on the computer. Just add this at the bottom somewhere. Copper deficiency is called Menkes kinky hair syndrome. In Menkes kinky hair syndrome, Marcelo, she's got orange colored hair. Orange like copper. Yes, she's copper deficient. You understand, Marcelo? Well, Marcelo, her hair, it feels like copper. And yes, she's deficient in copper. It's the most ironic syndrome I've ever seen. Okay? I saw one case of this. I mean, her hair was like copper wire. It comes across her face like that, and sometimes it'll cut her eyelid. Oh, just swollen, some bleeding. Sometimes you get an infection right over the eyelid. What do you think is the most common cause of death in that little girl, Marcella? With the hair just, cutting her face up like that. Was that? Was that? Heart failure. Oh, yeah, that's right. He thought about it for a second, though. Then he said, wait a minute. He did tell me, same answer. You see what I mean? You see how the slow programming? Before, you would have thought all that stuff meant anything. Listen to the question. Most common cause. It's got nothing to do with the vignette. The whole vignette is distraction, folks. Any question that says most common, I don't even read the vignette. It has nothing to do with the vignette. Answer it as is. The most common cause of UTI is always E. coli. I don't care what story you got to tell me. I don't care what syndrome we're talking about. I bet you it's still E. coli. That's the point. Okay, so the key was trying to distract you away with all that stuff happening in their face and then ask you a general question. Hey, what's the most common cause of death? Still same answer. Don't change a thing. All right, so copper deficiency. All right, movement disorders in middle-aged people. Huntington's is the most common cause. That's the 90%. And then Wilson's that we just talked about is the other 10%. This middle-aged person, 20 to 50, also got movement disorders, Jesse. You should always think of Huntington's first. So let's compare and contrast, Jesse. Huntington is autosomal dominant. That's different from Wilson's autosomal recessive. Well, Jesse, if you're autosomal dominant, one good gene, one bad gene. What's the chance of getting the bad gene, Jesse? 50% in one family, one parent has it. Good gene, bad gene, right? Makes sense to me? Makes sense to you? Makes sense to you? Okay. Jesse, what's the chance of getting it both parents have it? 75%. Never hits 100%. It's just, all you do is add another 50 times 50%, which is 25 more percent. So if one parent has it, 50%. One good gene, one bad gene. Both parents have it, you add another 25% to that. 75% is the maximum you can go in autosomal dominant. All right, here's some subsets. If you have an autosomal dominant gene, and yet you don't have the disease, that's called decreased penetrance. That's how you explain it. And that's what they're going to ask you on the boards. How do you explain this? Decreased penetrance. It didn't penetrate through the other genes that you had. Okay? Or if you got different family members with the same autosomal dominant gene, but different variations of the same disease, then we say variable expression. Variable expression. Okay? So autosomal dominant. So just sharing with you, there are really only 5 genetic patterns, folks. That's why I don't teach a separate genetics class. It's unnecessary. There's 5 patterns, and that's what I'm going to keep highlighting. And then you can slide in a lot of diseases under 5 categories. That's it. All right, so we've done X-linked dominant, autosomal recessive, now autosomal dominant. Well, other clues of Huntington's? Yes, ma'am. 50% chance of getting it if only one parent has it, 75% if both parents have it. Oh, yeah, if you got different family members with the same gene, but they have different types of the same disease, then we say variable expression. Yeah. All right, Huntington's has trinucleotide repeats. Involves a caudate nucleus, if they want to be specific, versus Wilson's involves the lenticular. It has anticipation, which means it comes earlier and gets worse with each successive generation. You understand, Miguel? All right. With Huntington's, they got too much movement. That's too much dopamine. So dopamine blockers will help decrease some of their movement. So antipsychotics help them a lot. Doesn't change the prognosis. They still die from it. Most common cause of death, folks, is suicide. Well, Narec, it's pretty hard to just watch yourself deteriorate and die. So most of them just want to get it over with. Now, India, why do they want you to know that? Because if the patient comes to you and says, Doc, you know, there's a family history of Huntington's. Should we get a blood test to check and see if I got it? You say no. Even if they press, you say no. You know why? Here's the big reason why, folks. Number one, there's nothing you can do about it anyway, so why do you want to screen for it? Except now they're going to go out and commit suicide. Okay? Number two, if they find out by genetics that they have it, the insurance companies will say that's a pre-existing condition. They will not pay a dime when that person ends up in the hospital. So you must make them aware of that. Don't do it. And so that's why on the Boris test, that's the answer. Discourage the patient. Give them some counseling, but do not run the test. Okay? Does everybody understand? You're trying to protect your own patient here. Remember, that's what we're trying to do. Sometimes a patient does not know what's the best for him. You, the doctor, if you know what's best, then that's what you ought to be doing. Okay? So, Huntington's and Wilson's. Well, there are 5 diseases of trinucleotide repeats, Miguel. So you want to know these 5. They also have anticipation. So that means they come a little sooner and they're more severe with each generation. So Huntington's being the main one. Fragile X, that's only some of the cases. I'm not saying all of them have it. Okay? In Fragile X, you get what they call uniparental disomy. That's totally different. Before somebody panics. Uniparental disomy means one parent, uniparental, carries both mutations. It's not supposed to be that way. One parent should carry one, another parent carries the other one. All right, uniparental oh, wait a minute. I'm talking about Prader-Willi. I spoke too soon. Sorry, uniparental disomy is for Prader-Willi. Fragile X, what we're talking about, that's also a trinucleotide repeat. So does Friedreich's ataxia. That's the neuromuscular we're talking about. Prader-Willi is the one with uniparental disomy. This involves chromosome 15. All right. Remember when mom carries both mutations? Then it's called Angelman's. It's, mom's little angel. She laughs all the time. Can't take nothing serious. I keep telling her she's smoking weed, but they won't believe me. All right. But I got my own theories. So anyway, and then Prater Willie. Prater Willie's got the voracious appetite, eats everything in sight. All right? But that's when dad. So I always think, proud papa. So dad carries both mutations on his chromosome 15. Myotonic dystrophy, we'll be talking about neuromuscular, also trinucleotide repeats. So very high yield list to know. So that means once they say trinucleotide repeats, you're down to 5 right away. Okay? Iron, that's it for heme and hemoglobin. You need ferrous, not ferric. Ferric is no good. Ferrous can bind oxygen. That's why you got to make sure that iron does not get oxidized, Joni, by giving it what vitamin by mouth? Vitamin C, and what vitamin in the blood? Joni? Vitamin E. All right, because it all depends on where they ask. If it's in the blood, you say E. If it's in the GI tract, you say C. Yeah, very good. And then iron is also necessary for complex 3 and 4 of electron transport system. And finally, the trace elements, which go pretty quickly. You got this list, and here's what you need to know. Chromium enhances insulin action. So this is the one that can cause diabetes if you're deficient in it. So that means, Eric, they'll give you a type 1 or type 2 diabetic and ask you, boy, what trace element do you want to make sure they're getting in their diet every day? I think this is the one they're looking for. Because if you're deficient in chromium, the diabetes just gets worse. Everybody understand? All right. Chromium enhances insulin action. Selenium, necessary primarily by the heart, Gretchen. The heart needs a whole lot of selenium. If you got too much selenium in your system, or somebody poisoned you with arsenic, your breath will smell like garlic. So that's a nice clue. I was on House MD. I knew that. I got that one. I love House because it leaves you thinking. You're always trying to figure it out before the end when they tell you what it is, Of course, the last few times, they've come with some weird, rare disease. I'm like, come on, House, man, come on, get in the books, give me a good one here. They pick up rare stuff now. All right, so I think it was probably during the writer's strike. They just picked some rare disease out of some book. All right, so if breath smells like garlic, think of selenium or arsenic poison. Anytime you're deficient in it, the heart, who needs so much of it, you get a dilated heart. So really non-specific, unless they give you that garlic smell in the patient's breath. Selenium toxicity. Molybdenum and manganese are necessary for a lot of enzymes and glycolysis. Which ones? They won't ask, Janice. But they will ask you what enzyme needs both of them. Key. Xanthine oxidase needs both of them. It's the same one that makes uric acid, Leanne, for gout. You see, so we can tie trace elements to gout if we want to. This is how they make it a boys 2 or 3 question, folks. Because they know that a lot of physicians have lost track of the basics. It's just, treating for this for gout. And then when they ask, well, gee, what trace element might you want to make sure? Oh, boy, anyway. The key is know the connections. All right, 10. No unique clue. Necessary for hair. Heck, so is every other vitamin. So I think I've seen one question about 10 in 20 years, and that's all they ask. What tissue use it? Hair? Yeah, because there's nothing unique about it. All right, fluoride, necessary for teeth and bone growth. If you have too much fluoride in your system, thyra, it'll block an enzyme in glycolysis called enolase. Well, in the old days, thyra, children who needed fluoride, they would have them eat like rock candy. There were rocks of fluoride. And they would bite into it like rock candy. Well, then years went by and they decided, you know what, we need to figure out how much of every nutrient a person really needs. That's called the RDA. Recommended daily allowance, you know what that term means? How much of any nutrient does a person need to prevent disease? That's what RDA stands for. Even though it's recommended daily allowance, but you got to understand, how do they come up with this number? That number is how much do you need to prevent disease in 95% of the population. Remember, bell-shaped curve. That's it. We always try to protect 95. The other 5, we leave out there. Okay? So when they found out what the RDA for fluoride was, it was 6 parts per million. You don't have to write that down. It's just something I remember. 6 parts per million means 6 molecules of fluoride swimming around in a million molecules of water. Which means, if you just put your tongue on a rock, you already had your RDA for fluoride. But it was too late, Malik, too late. All these children have been biting into rocks full of fluoride, chewing on so much of it, and then they started showing up in local emergency rooms with all kinds of illnesses, man, and then you do an x-ray, you see these bright, white, shiny teeth and bones. Do you hear me, Malik? You understand, Malik? Man, the problem is, if you got bright, white, shiny teeth and bones, what do you think was the most common presenting symptom for that, for these children? So let's see if Prethy knows. When they got bright, white, shiny, bright, white, shiny teeth and bones. Fluoride overdose. And I'm saying just shiny white bones on x-ray. What was the most common presenting symptom when they showed up to the emergency room? Let's try Rick. Kidney stones? Close. What do you think, Key? What do you think, Janice? Weakness of what? Thank you very much. What infections did they have, Janice? What's their skin look like? Dry. What about their hair? What about their bone marrow? Depressed. What about their nails? Brittle. What about their breast size? Atrophy. What about the sperm count? Low. What about the GI symptoms? Nausea, vomiting, diarrhea. What part of the nephron was shut down first? PCT. What cancer can they get if they live long enough? Skin followed by. GI followed by. Oh, bone marrow. But the most common cause of death, if you don't catch it early enough, is what? Class dismissed, baby.